Hello, this is Jacqueline Booker. I'm just going to share with you a case study about the lumbar spine. My patient was a 62-year-old male, fairly sedentary lifestyle, liked to read and walk, was sent here on January 30th with a referral diagnosis of lumbar stenosis and degenerative disc disease. His main complaint was twinges and sharp pain across his lower back with shooting pain down into his lower extremities. Injured himself on the 15th of October. Essentially, he woke up with the pain. As you can see here, the outcome measure for his photo. The primary complaint was that central pain right in his low back with pain in his left lower extremity down to the calf and right lower extremity down posterior thigh proximal to the knee. As you can see here, kind of constant lower back pain with intermittent lower extremity symptoms. You can see what I thought the structures might be referring. Essentially joints underneath the area, lumbar segments and facet joints. You can see some of the areas I thought might refer, and contractile structures, especially erector spinae and transversus spinalis, with the outlier being a tumor or growth. My primary hypothesis was mechanical low back pain with intervertebral disc herniation, secondary being that lumbar stenosis and stability problems due to lumbar hypermobility. His aggravating factors were essentially for P1 walking greater than 15 minutes, any prolonged positioning like standing, ascending stairs. He had worse pain first thing in the morning. He wasn't able to pinpoint his aggravating factors for P2 and P3. Just seemed like as P1 got worse, or if he added a sudden twisting movement, that's when those came on. Sleep in 24-hour pattern. The pain is worse first thing in the morning, better like towards the afternoon once he's had a chance to rest and move around a little bit. Duration of his current symptoms about 3.5 months. No known mechanism of injury, and essentially has progressed from that central low back pain down into the lower extremities. He's had a similar episode of back pain like over 20 years ago that resolved without treatment. And so far, he's just seen a neurologist who referred him to pain management. As far as medical history, overall, high blood pressure that he says is controlled with meds, and diabetes, the same thing, controlled with medication. No red flags, yellow flag, both depression questions answered yes, but patient stated not really looking for referral at this time. From the history, I'll use his high pain during walking as one asterisk sign, and essentially that 9 out of 10 pain with rotation as well. Primary and secondary hypothesis, still, feeling like maybe lumbar radiculopathy with that spinal stenosis, possibility of peripheral neuropathy with diabetes, and still that mechanical low back pain. Ruled out. No musculoskeletal things can be ruled out during the history. And non-musculoskeletal, probably not diabetic neuropathy due to the pattern described. The severity of the condition, I would say, is fairly severe, as you can see here, due to high pain and how much it limits his function. With the irritability, about moderate. Doesn't take much to irritate it and stays irritated for a while. And I still think it's musculoskeletal, and it's in that kind of chronic stage. And I also believe that the condition is stable and reproducible. In order to rule in and rule out the top 3, I'd want to do my lumbar and hip range of motion. I'd also want to do my neurological screen, just to see, along with those radiating pains, if you have any sensation or muscle deficits. Muscle length, all of those tests there are kind of in accordance with our treatment-based classification groups, as seen here with the categories and qualifiers. For the first day, I probably won't do a directional preference exam, a thorough one, due to, one, the pattern in history didn't really lead me there, but also that could really irritate his symptoms and not allow me to get to the rest of the test. With the physical exam, I found no contraindications for the exam. Posturally, as you can see here, slightly flexed, increased waist circumference. Essentially, my functional asterisks are lumbar extension and flexion. They both aggravate his pain. And he had a positive active straight leg raise, indicating some stability issues. Cleared on the rest of his joints there. Neurological examination was normal. and his range of motion, you can see here, is fairly limited in most planes, with significant pain and lower extremity symptoms reproduced. With the palpation here, you can see that only area of tenderness was left lumbar multifidi, just locally, and didn't radiate pain anywhere. Central PAs were hypermobile and not painful. Manual muscle testing was all 5 out of 5, but hip flexion recreated pain. Muscle length, definitely tightness in the hamstrings and hip flexor. And motor control, patient is able to initiate that transverse abdominis contraction, but it's less than 5 seconds of a consistent contraction, and had difficulty not bracing. The special tests were a positive active straight leg raise, didn't have a positive fit test, and didn't have a positive straight leg raise. Essentially, my primary hypothesis is mechanical low back pain secondary to spinal stenosis, with the kind of complication of lack of core stability. The historical exam, as you can see here, those same asterisk signs I mentioned before, and the physical exam, lumbar flexion, extension, and that active straight leg raise. I want to see, after we've worked with him a little bit, if that becomes negative. Prognosis here is that I expect the patient to achieve centralization of the symptoms, but probably not complete cessation of pain. 6 to 8 weeks for recovery. I expect to see the patient 2 times a week in the beginning to get the pain down, and taper to 1 time a week as the symptoms centralize. I plan the patient wanted to eliminate pain and be able to sleep. I anticipate that their worst pain will be significantly decreased, be able to stand longer, essentially function better with increased range of motion. I'll know that patient is ready for discharge when the symptoms are no longer in the lower extremity, and they're able to do the functional core exercises without symptom aggravation, and that the patient seems motivated and independent with their exercises. If 2 weeks pass without a noticeable improvement, I will definitely reconsider my treatment. Overall, plan to start with traction to try and centralize symptoms, and also do spinal manipulation followed by core stabilization to help reactivate those muscles. Any questions?